afternoon, everyone. I welcome you all to today's afternoon session. So I welcome Director General Dr. Nageshwar Rao sir, Director Dr. C.V. Rao sir, Principal Dr. Bhimeshwar Rao sir, Academic Convener Dr. Ishwar sir, and I welcome all the faculty, senior and junior residents for today's afternoon session of clinical case discussion of interesting cases. So today we have total 4 cases for discussion. The first case, migrated common bile duct stent from Department of Gastroenterology, prevertebral abscess from Department of ENT, tuberculosis as a cause of acute abdomen, a clinical series and review of management outcomes from Department of General Surgery, empyema with a twist, unusual phases of tuberculosis from Department of Pulmonary Medicine. So we'll start the first case, migrated common bile duct stent from Department of Gastroenterology, presented by Dr. Sai Vishnu, Junior Resident General Medicine. Session will be moderated by Dr. Bhaskar Rao sir, gastroenterologist.
We will be presenting an interesting case on migrated biliary stent, moderated by Dr. Bhaskar Rao sir. A 70-year-old woman presented with hospital with a chief complaint of right upper abdominal pain since 1 week, alert discoloration of eye since 5 days, and dark colored urine since 5 days. History of present illness. Patient was apparently asymptomatic 1 week prior to presentation, after which she developed abdominal pain in right upper quadrant, which is insidious in onset, progressive in nature, dull aching, localized to right hypochondrium, non-radiating, aggravated by food intake, and there is no relieving factors. Associated with alert discoloration of eyes and dark colored urine since 5 days. There is no history of any fever, chills and rigors, no nausea or vomiting, no loose stools or constipation, and there are no abdominal distinction, no history of clay colored stools or pruritus, no previous similar episodes of jaundice, no epigastric pain radiating to back, no history of loss of appetite or significant weight loss. No history of GA bleed or blood transfusions. Past history. No history of similar complaints in past. Not a known case of diabetes, hypertension, coronary artery disease or bronchial asthma or tuberculosis. Not allergic to any drugs. Person history. She is a mixed diet. She is on mixed diet, appetite normal bowel and bladder habits, and there are no addictions. General examinations. General examination. Patient is conscious, coherent, oriented to time, place, person, moderately built and nourished. Her weight is 55 kg, height is 150 centimeters, BMI is 24. BP was 110/70, saturation was 99% with room air, and the respiratory is 18 cycles per minute. She is febrile and pulse rate is 1 at 1 beats per minute, which is regular. There is no pallor, sclerectus is present, there is no cyanosis, clubbing, lymphadenopathy and pale later. Her parabdominal examination was done. On inspection, abdomen is normally in contour, umbilicus is inverted and central moves with respiration. And there are no signs of no dilated veins or stria, and there are no visible peristalsis. On palpation, abdomen is soft, tenderness is noted in right hypochondrium, and there is no guarding, no rigidity, and there is no palpable mass or organomegaly. On percussion, normal tympanic resonance is present and no dullness. Auscultation, bowel sounds present. And remaining system like cardiovascular system, respiratory system, and central nervous system are normal. And our differential diagnosis was done benign causes was either it is a CVD stone, a choledocholitis, or it is any benign biliary stricture, or any carcinoma of head of pancreas, or periampullary carcinoma, or cholangiocarcinoma. Investigations on day of admission. ECG was done. It was a 12-lead standard ECG with a rate of 100 beats per minute, normal rhythm, right axis deviation, and there is no normal. Ultrasound abdominal pelvis was done. And the impression was the prominent biliary system with proximal CVD dilation, suggestive of a distal biliary obstruction to rule out polydocholithiasis, polycystitis, or any gallbladder mass. And MRC plus ECT abdomen is advised for further evaluation. Complete blood picture was done on day 1, which was mild anemia, and there is normocytic normochromic picture, and rest is normal. Total LFT was done on day of admission. Total bilirubin showing 11 with a direct bilirubin pattern of 6.3 and indirect of 5.3. ALP was 262 and enzyme showing mild increased SGOT of 120 and SGPT of 115. And the impression is cholestatic pattern suggestive of any obstructive jaundice. And coagulation test like INR is normal. And remaining tests like renal function test, serum electrolytes, and viral panel and COA is except bilirubin is present in complete urine examination. MRCP was done.
This is a coronal section of MRI showing the presence of a hypointense focus in the CBD. There is retrograde dilatation of the proximal CBD, and there is also IHBRD present. On the axial image, we can see the similar focus in the CBD, which is a calculus suggestive of choledocholithiasis. Here we can see few other hypointense structures which are air foci.
And here is a report, biliary tree showing filling defect in common bile duct measuring 1.5 into 0.5 centimeters, located proximal to mid common bile duct, common hepatic duct, and intrahepatic biliary radicals are dilated. And the impression is choledocholithiasis, common bile duct stone causing biliary obstruction with upstream dilation. 2D echo was done. There is no regional motion abnormalities, and then there is normal LV function, ejection fraction of 60, and there is decreased diastolic compliance, no mitral regurgitation, arterial regurgitation, tricuspid pulmonary hypertension. RBS is 20, and there is no PE clot vestation. IVC is normal. Treatment was the treatment given was given with tablet pantoprazole, injection vitamin K, and for analgesic tablet atrazepam was given, and she was planned for ERCP. And ERCP was done on day 2. The indication was choledocholithiasis. She was done under general anesthesia, and select to common bile duct cannulation was done with sphincteroscopy, which was confirmed by bile aspiration. Guidewise was passed with the right system, and cholangiogram was taken, and CBD sphincterotomy was done. And here is a cholangiogram which shows hugely dilated proximal CBD, common hepatic duct, and intrahepatic biliary duct radicals with filling defect seen at mid CBD with narrowing of distal CBD. And CBD sphincterotomy was done. And we have done multiple balloon sweeps, and along with stone extraction was done, and endotherapy was done with 7 French 7 centimeters double pigtail stent, which is a plastic stent was placed. There was a free flow of bile from the stent at the end of the procedure, and the impression was ERCP shows dilated CBD, CHD, and intrahepatic biliary radicals with choledocholithiasis, and CBD clearance and stenting was done. And she was advised with the cholecystectomy, CBD stent removal, and check cholangiogram within 2 months after post cholecystectomy. And this is a trend of bilirubin. On day of admission, it was a total bilirubin of 11, and post ERCP it was gradually reduced to 12 and 6.9 on day 3. And here you can also see the gradual reduction of alkaline phosphatase from 262 to 217, and enzymes from 120 SGOT to 40, and SGPT from 150 to 44. 2 days after ERCP stenting, patient was discharged and planned for cholecystectomy. Patient was stabilized and discharged in stable condition, planned for intraoral cholecystectomy, and cholecystectomy was performed in our hospital after 1 week. And the patient again came to hospital within 1 month after the discharge with diffuse abdominal pain since 4 days and fever with chills since 2 days. On history of parental illness, patient was asymptomatic for 1 month after previous treatment, where she developed high-grade fever with chills for 2 days, and it was associated with generalized weakness and diffuse abdominal pain since 4 days. It was insidious onset, progressive in nature, dull-aching, non-radiating, aggravated by food intake, and there is no history of vomiting or GI bleed, and all this is deteriorated within 48 hours. On examination, patient is sick looking, and icterus is present, and diffuse abdominal tenderness is present, and gauding is present. And on chest auscultation, the bilateral non-voice breath sounds. On vitals, her BP was 80/60. She's on shock, and she was given with fluids, and after which, even though when blood pressure was not maintained, she was kept on uninterrupted support with injection noradrenaline 8 mg per ml, 8 mg per minute, and injection vasopressin 2.5 ml per hour. And her pulse rate was the 102, which is tachycardia. Saturation 96 at the room height, GRBS was 110. And ultrasound was done during this time, and it shows grade 1 fatty liver and bilateral mild pleural effusion. And on biliary system, the common bile duct is 5 mm, mid and distal CBD obscured by shadow, and here you can see the nose CBD stent visible.
This is a frontal chest shadow of APDU. It is in rotation. Cardiac shadow is grossly within normal limits. The both don't suffer from a well outline, but there is a minimal planting of bilateral claustrophrenic angles indicative of mild pleural effusion. Both lung fields are clear to the visualized extent.
And these are the investigations done during this admission. Our hemoglobin was 9%, and WBC was 52,000, which was gradually, which was very high, which is neutrophil predominant, and platelet showing 50,000, and RBC of 2 lakhs. and urea was 65, creatinine was 1.3. Here at left it shows total bilirubin of 7.9, which is direct pattern of 7.3. Her alkaline phosphatase was 287 and enzymes was high with 241 and SGPT of 262. Her albumin was 2.4. Here you can see iron was showing 1.4 and CV showing bilirubin was +2. Her electrolytes were normal. Here emergency ERCP was done in view of sepsis, polystatic jaundice and migrated CB stent and suspected cholangitis. Patient was taken for ERCP. Here during ERCP, you can see pus is coming from the bile duct. Patient was treated with injection meropenem, 1 gram and pantoprazole, paracetamol, ondansetron, IV fluids, and patient is off inotrope support by day 3. Patient was extubated on day 5. Here are the CBD trends on day of admission to at the time where she was recovered of inotropes and extubated from WBC count from 52,000 to 8,000. And here are the LFT trends from day 1, 87 to 0.9, and air bilirubin also gradually decreased from 7.3 to 0.7, and enzymes SGOT and SGPT from 241, 262 to 30s and 20s. And also renal recovery was done from urea 65 to 20 and creatinine from 1.3 to 0.7. Alkaline stable. Her cultures was sent from the biliary pus. We have sent culture where E. coli was isolated. It was sensitive to meropenem and patient was kept on meropenem. A clinical improvement was done after ERCP. Source control achieved with ERCP, and there is gradual improvement of hemodynamics like blood pressure and organ failure. Resolution of sepsis with appropriate antibiotics and supportive care. Patient was recovered and discharged in stable condition. Final diagnosis was septic shock with multi-organ dysfunction syndrome, secondary to cholangitis, secondary to migrated CBD stent distal.
Case is open for comments and the stent is removed or kept in surgery.
During follow-up, we have removed the stent, sir. This case significance indicates that the emergency of the need of procedure until unless we drain the biliary system, which is filled with pus, the patient will not stabilize even after giving so many antibiotics, sir. After giving that draining the pus only, the patient able to stabilize, sir. And also, after first ERCP, biliary system was cleared, but again patient came with cholangitis because some of the times while manipulating the biliary system during cholecystectomy, some of them may be slippery into the common bile duct and which may be causing sometimes obstruction. That's why we do second time before removing the stent. We check cholangiogram. That is, we balance with again the system and remove the stent, sir. But here the patient has migrated stent. That's why she landed in cholangitis and she has a tough course, sir.
When migrated, it is patent enough to make you to drain the pus.
Yes, sir. We have given the sphincterotomy, sir. That's why you are able to easily enter the biliary system, sir. Biliary sphincters. And also, we want to heartful thanks to our ICU, Dr. Basha sir, for giving good ventilator support and taking care of, sir, and also anesthesia support, sir.
Both your blood culture and pus culture are equal. Two cultures.
Blood culture.
Pus and blood culture both are equal. That means she had an equal septic bacteria. Am I right? Comments? No, it is followed. After that, not doing well. Surgeons, surgical faculty, any questions?
So we find quite difficulty with these cases, like patients with the post-ERCP stunting
and we have also received so many cases from Bhaskar sir, where there are there is only one migrated stunt distally, but we have sir have referred some cases where we have operated 2 to 3 times passed out stunt. But what the patient feels is actually they think the stunt have relieved the cholangitis. So the fever subsided, the pain subsided. So patient thinks everything is done, and the patient won't return back to neither sir or surgeons also. So the stone itself is impacting, and after 1.5 years, when the stone gets obstructed, they'll end up in septic shock like this. So then it is again a tricky situation, because even sir should again put the stent, then only we can do the surgery. So in recent times, what we are doing is we are asking sir to come to the OT and do the ERCP. If possible, we are doing the surgery in the same setting, which will reduce the chances of injuries or other complications.
Therefore, stent migration or otherwise is a phenomenon. What is the incidence?
Stent migration is almost, we see 5 to 6-7% of cases, sir. Most of the times it migrates distally, sir. That is also okay, but migration into the proximal into the biliary system is very difficult thing, sir, because it may cause perforation and also sometimes cholangitis. Removing the stent also becomes difficult, sir, if it migration into the proximal into the biliary systems. Migration is common, sir, almost 5 to 7%.
Okay.
Sir, it is actually like a double-edged sword, sir. One is migration, sir. The second problem is whenever the patient feels everything is relieved, the stone size increase in the CBD. So we encountered a case of 4 to 5 centimeter CBD, where the stone is already almost the size of a rock. So we have to cut open the plum. That is, first we went in with laparoscopy, then we have seen the stone size, then we have converted to laparotomy. Then what we have found is the stent itself was entangled within the stone. So it became an itis for that. So only after we cut open the stone, we could find the stent. That is one interesting case.
Can radiologist make the ultrasound related stent component? Unless ERCP, not totally.
The easiest way to assess the stent, because they are all coated with radio-opaque material, it's very easy to assess in the radiographs. And especially when you have size, dimensions, everything, 7 bulbing tile, then it's very easy to assess. Then followed by that, it's very confusing to assess the stent in MRCP. So if you to exact give localization, next step is plain CT scan itself.
There are no questions? Then we'll go to the next case.
Thank you, sir.
Announcement from Dr. Shrikant sir, Vice Principal. We have an important announcement from our principal, Dr. Bhimeshwar sir.
Good afternoon, all of you. I'm very happy to inform you all that our medical education unit and the skills training center have been renovated, and our secretary, Dr. Sri P. Lakshman Rao Garu, has consented to inaugurate our renovated medical education unit and the skills training center tomorrow, that is the 7th, at 2:30 p.m. I request all the faculty, senior residents, all the HODs to kindly attend that and make it a grand success. Thank you.
The second case, prevertebral abscess from Department of ENT, presented by Dr. Srujana, Junior Resident ENT. Case will be moderated by Dr. Satish Chandra sir.
Good afternoon, everyone. I am Dr. K. Srujana Rachel, second year junior resident of the Department ENT HNS. I am presenting an interesting case of stiff neck under evaluation, and the moderator of this session is Dr. T. Satish Chandra sir, Professor and HOD of the Department ENT HNS. A 55-year-old male presented to the emergency room with chief complaint of neck pain and headache since 15 days. The patient initially presented with neck pain and headache 15 days back, for which he was evaluated at an outside hospital and had been diagnosed as query prevertebral or retropharyngeal abscess and was initiated on medical management for 7 days. Despite the treatment, the symptoms persisted and worsened, prompting the presentation in ER. There is history of neck pain and headache present since 15 days, which is of grade 3 severity according to International Headache Society. There is history of intermittent episodes of fever present since 15 days, and there is history of neck rigidity present. There is no history of limb weakness. There is no history of vomiting. There is no history of signs of meningitis. There is no history of difficulty in opening of mouth, and there is no history of odontogenic infections or any trauma or any foreign body ingestion. There is no history of chronic cough, night sweats or weight loss. There is no history of tuberculosis or trauma or fractures present in the past, and the family history is not significant. The patient consumes mixed diet and his sleep and appetite are normal. His bowel and bladder habits are regular, and he is a known alcoholic since 20 years and consumes 180 ml of whiskey twice weekly. He is a known case of diabetes mellitus for 10 years and consumes tablet glimepiride plus metformin 2/500 mg per oral twice daily and tablet pioglitazone 15 mg per oral twice daily. He is also a known case of hypertension for 10 years and consumes tablet telmisartan 40 mg per oral once daily. Since the past 15 days, he has been on IV tramadol and other transdermal pain relief patches. On clinical examination, the patient was conscious, coherent, cooperative, and well oriented to time, place, and person. He is moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. The vitals at the time of examination are BP is 140/90 millimeters of mercury measured in the right hand in supine position. The pulse rate is 88 beats per minute. The respiratory rate is 18 cycles per minute. The temperature is 98.6 degrees Fahrenheit and his saturation is 99% on room air. On visual analog score, the pain score is seen between 8 to 9, suggesting intense severe pain. On local examination, on inspection of neck, the neck is seen in flexed position with difficulty in movement of neck in all directions and there are no obvious swellings noted. On palpation, there is diffuse tenderness present all over the neck and there is restricted movement of neck seen on passive and active range of motions in all directions. The examination of oral cavity and oropharynx. The mouth opening is seen painful but adequate, admitting patients 3 fingers vertically. The buccal mucosa appears congested with white patches and the anterior and posterior tonsillar pillars are seen congested. The posterior pharyngeal wall is also seen congested. In the video laryngoscopic examination, the base of tongue, vallecula, epiglottis, bilateral arytenoids and bilateral epiglottic folds are seen to be normal. The bilateral true and false vocal cords are seen moving equally with respiration and phonation, and there is no pooling of saliva present in the piriform fossa or any bulges noted in the posterior pharyngeal wall. On examination of nose, there is deviated nasal septum to left with bilateral inferior turbinate hypertrophy, and on examination of ears, the external auditory canal appears to be normal bilaterally with retracted tympanic membrane. On investigations on the day of admission, the total WBC count appears to be slightly elevated of 12 into 10 power 3 cells per microliter, and the neutrophils are slightly elevated of 76, and the lymphocytes, there is a slight dip of 17. The platelets are also elevated of 452 into 10 power 3 per microliter, and the ESR is also on the higher level of 53 mm per 1 hour. As the patient is a known diabetic, the RBS came out to be as 348 mg per dl, and the following day we have ordered for FBS and PPBS, which came out to be as 244 and 292 mg per dl with 11% HbA1c. The renal function test and the serum electrolytes appear to be normal with a slight dip in the sodium levels, and the complete urine examination, which was done on the day of admission, there was slight elevation of glucose and ketone bodies of 2+ and traces of blood as seen with 1% leukocytes seen, and in the microscopic examination of the urine, the red blood cells were seen as 5 per high power field and white blood cells as 8 per high power field. The patient is further evaluated with CECT neck for the extensions and for any bony involvement.
These are axial CCT sections of the neck, showing us the presence of a relatively defined heterogeneously hypodense lesion with peripheral enhancement involving the prevertebral space. And here on the left side we can see the extension to the left to paraspinal muscles also. Next. These are sagittal and coronal images of the same patient, showing us the presence of the same abscess. Superiorly it is extending up to the clivus, lower cervical vertebra. These are sagittal T1 post-contrast images of MRI, showing us the presence of heterogeneous abscess in cervical region, which is showing peripheral enhancement. Here we can see the involvement of the posterior elements also. So this was given as a prevertebral abscess.
On taking into consideration of the radiological evaluation, we have diagnosed the patient as having deep neck space infection, which is the prevertebral space abscess. The patient was planned for incision and drainage of abscess, followed by microbiological assessment. Intraoperatively, we have managed the patient by a lateral cervical approach. An incision is given anterior to the sternocleidomastoid muscle, and the superficial cervical fascia is incised. The superficial layer of the deep cervical fascia is also incised, and the sternocleidomastoid is identified and it is retracted laterally. The carotid sheet is also identified and it is retracted posteriorly, and the incision is continued deeper. The buccopharyngeal fascia is also identified and it is incised, but after the buccopharyngeal fascia is incised, in the retropharyngeal space we could not identify any pus, and so the prevertebral fascia was also incised, and then after incising the prevertebral fascia we have identified pus in the prevertebral space. The pus is being syringed out from the prevertebral space and it is sent for the microbiological examination. After that, the wound is being thoroughly washed with betadine and a drain is kept in the prevertebral space for any further collection, and the wound is closed in layers. The pus has been sent for culture and sensitivity, and it came out to be as Klebsiella species, which is having sensitivity to various antimicrobials like gentamicin, imipenem, amikacin, chlorotrimmoxazole, cefoperoxam, cefotaxime, piperacillin, ciprofloxacin, cefixime, cefpodoxim, and meropenem. And the pus was also sent for RT-PCR, in which there was non-detection of Mycobacterium tuberculosis complex and non-tuberculosis mycobacteria. In the post-operative care, the patient is treated with IV meropenem 1 gram twice daily and IV levofloxacin 750 mg once daily for 7 days and IV metrogyl 500 mg thrice daily for 3 days, and on discharge we have kept the patient on tablet levofloxacin 750 mg once daily for 5 days. The antihypertensives and anti-diabetic medications are continued as per the physician orders, and the drain removal was done on POD 4. The suture removal was done on POD 7 and the patient was discharged in a stable state.
These are the neck radiograms POD 6 and POD 14, and we can see mild soft tissue thickening at the level of C7 vertebra with tiny radiolucent areas within. And in the X-ray of POD 14, it's only mild soft tissue thickening without any air foci. The rest of the findings are normal. The alignment of the cervical spine is normal. There are no cortical breaks detected.
The neck is divided into several compartments, which is consisting of superficial fascia and the superficial layer of deep cervical fascia, which includes the sternocleidomastoid and the trapezius, and the middle layer of the deep cervical fascia, that is the pretracheal fascia, which encloses the esophagus trachea, and behind it we have the buccopharyngeal fascia, and in between the buccopharyngeal fascia and the alar fascia we have the retropharyngeal space, which is extending from the base of the skull to the mediastinum, and also behind the alar fascia and the prevertebral fascia we have the danger space of the neck, which is extending from the base of the skull till the diaphragm, and behind the prevertebral fascia and in front of the cervical vertebra we have the prevertebral space, which is extending from the base of the skull to the coccyx. The prevertebral abscess is a rare subtype of deep neck space infections, accounting for less than 10%. Its etiology in the elderly can be due to cervical vertebral body infection or necrosis as a result of Pott's Puffy tumor, and it can be due to degenerative spinal disorders like cervical spondylodiscitis or osteomyelitis, iatrogenic or traumatic insult, or it can also occur in immunocompromised state, that is in diabetes mellitus. The common organisms which can lead to this abscess are Staphylococcus aureus and the Streptococcus species. Gram-negative organisms like Klebsiella, as seen in this case, are increasingly reported. The presentation is often insidious and non-specific initially, leading to delayed diagnosis, and when neglected, the infection in the prevertebral space can spread inferiorly to the mediastinum, superiorly to the epidural space, anteriorly to the retropharyngeal space, and laterally into the parapharyngeal space. And it can lead to complications like airway obstruction, cervical osteomyelitis, epidural abscess, which can lead to spinal cord compression and paralysis, and descending necrotizing mediastinitis, pericarditis, and septicemia and septic shock.
Question open for discussion, Professor. Anything to say? Satish?
Yeah, this is a rare instance where there is no obvious predisposing factor. Most commonly what we see in those cases is either it's a vertebral body infection or maybe because of foreign body infection. This is literally some sort of a spontaneous. We evaluated everything. CT was not showing any bony infection, so no soft tissue infection. Even to call that one as a retropharyngeal lymph node necrosis also, it was there in the prevertebral space, the retropharyngeal space. So some unusual presentation.
Is there any possibility that he is having a mixed diet and some amount of prick onto the posterior pharyngeal wall?
That's the only thing that can explain this. I mean, vigorous neck movements.
Because he started with difficulty of flexion rather than the other way around, vertebral and vertebral pathology, in which you will have a little amount of extension. And my question to you is, you often see parapharyngeal abscess going for prevertebral or prevertebral coming to parapharyngeal anatomically?
Parapharyngeal going into prevertebral space.
Prevertebral space is not easily accessible. So parapharyngeal will go to retropharyngeal. So prevertebral is a rare entity where usually we see secondary to the vertebral body infection.
We might often see the prevertebral or the cold abscess in tuberculosis many a number of times. And fishbone which inoculated, and then the force will take it out and forget it about. And then will be large and goes into the posterior pharyngeal to prevertebral component. And in diabetics, this guy had a Klebsiella component present in diabetics. Then they might have had some amount of bacteria landing in prevertebral component because the vertebral plexus are veinless, valveless. Therefore, for many parts of the gut, they can go into the system and make a landing, which is not amenable for easy access because it bypasses the valves and other group of lymphatics. Nidus may come after 1 or 2 months or 3 months, he started having separative component in the absence of vertebral pathology. That's why it is rarity. But in gooder windows, those parapharyngeal and prevertebral component going to involve those two great vessels and then coming jugular foramina and jugular involvement and Lanier's syndrome and other things.
Yeah.
Here also we presented Lamiers without abscess but a small amount of infection. Anything more?
About 20 cc pus was drained.
Symptoms for how long?
Since 15 days only the patient presented with
No pain, nothing, only head pain. Fever is not there.
It was there.
Fever is there.
Yes, ma'am.
Pain is first, then fever occurred. Fever occurred and then pain.
Pain occurred first.
Any radiological comments? How often you might have seen? Without asking my question.
Real pus or mixed with blood?
It's mixed with blood.
No, real pus only, ma'am. While the operating field it looks like that, but it's a clear-cut pus.
Yeah, usually just like that Satish told, it's usually in the prevertebral space, it's from the spine infection or nodal spread, and retropharyngeal immediate one is usually due to foreign body injection. Without these two
Post instrumentation by the
surgeon, okay, whatever.
Gastroenterologist.
And it's very rare to have spontaneous, but did we work up anything for tuberculosis, the same bus? Tuberculosis can have without bone, there is soft tissue. Culture, CB-NAT.
The TB-NAT was negative.
Okay. So it could be diabetes which has predisposed, likely, with some trivial incident.
But by the time the tuberculosis produces a prevertebral abscess, we must have a clinical indication of the vertebral pathology and the spine.
Usually.
And done.
Usually.
Here, this fellow had more flexion component. There, they will have an extension component of the spine.
Basically, that's because of the spasms that he is listing in his listing position.
Thank you. Next case.
Tuberculosis as a cause of acute abdomen, a clinical series and review of management outcomes. The case is presented by Dr. Sandeep, Junior Resident General Surgery. Session will be moderated by Dr. Rahman Sir, Professor and HOD General Surgery. Dr. Pradeep Sir will moderate the session.
I am Dr. Sandeep, final year resident from Department of General Surgery. Today I am here to present a case of 27-year-old female presenting with diffuse abdominal pain, who is a resident of Gannavaram, presented with diffuse abdominal pain since 1 month. Patient pain was insidious in onset of 1 month duration, dull aching, non-radiating, intermittent with moderate intensity, no aggravating and relieving factors. Patient has no history of nausea, vomiting, fever, no abdominal distension or early satiety, no altered bowel habits or weight loss, no urinary complaints. Patient has no comorbidities. Patient has been investigated outside which showed abdominal TB. Patient is referred to our institute for exploratory lab work. Patient has no history of similar complaints in the past. Patient takes mixed diet, regular bowel and bladder habits. Patient sleep and appetite was normal. Patient has no allergies or addictions. Family history is not significant. Attained menarche at 15 years, regular cycles, or P1, L1 and last LMP was 15. Coming to general examination, patient is conscious, coherent, well-oriented with time, place and person, well-built and nourished, no signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema. Vital signs were normal. On coming to abdominal examination, abdomen was distended with umbilicus in midline inverted, all quadrants moves equally with respiration. Patient has no scar, swelling, sinus, fistulae, visible pulsations, peristalsis and engorged joints. On palpation, tenderness is present in all quadrants, maximum in hypogastrium. All inspectory findings are confirmed with no local rise of temperature, no expansal cough impulse, hernial orifices normal, external genitalia are normal. Patient has no guarding or rigidity, no rebound tenderness, no hepatosplenomegaly, no palpable cough impulse. Tympanic node is present in all quadrants of abdomen, no free fluid detected. Auscultation, bowel sounds were present. Coming to parectal examination was normal. Systemic examination was normal. Provisional differential diagnosis was TB peritonitis, pelvic inflammatory disease, endometriosis, inflammatory bowel disease, chronic appendicitis or appendicular mass. Coming to investigations, ultrasound abdomen pelvis showed an ill-defined soft tissue adjacent to uterus with omental thickening, collapsed bowel loops with thick echogenic fluid, which is suggestive of endometriosis, but differential diagnosis can be tubercular peritonitis. Advised MRI pelvis with contrast and ascitic fluid analysis for further evaluation. Hematology and renal investigations were normal. LFTs and coagulation profile was normal.
Frontal history of behavior, other previous symptom, the cardiac side is within normal limits. Bilateral domes of diaphragm are well outlined and bilateral costopenic canals are free. Both lung fields are to the visualized extent.
I had taken the history. Is she an asthmatic in the childhood?
No, sir.
Not elicited or not known?
Not known, sir. MRI abdomen pelvis was done outside, which showed adnexal inflammation, bilateral adnexal tissues inflamed with mild diffusion restriction, bulky, thickened fallopian tubes. Adhesions were noted between both ovaries adherent to uterus. T2 iso hyperintense areas around adnexa, uterus, small bowel and sigmoid colon. Likely diagnosis can be pelvic endometriosis with adhesions. MRI other findings were diffuse inflammatory changes with omental thickening in left hemi-abdomen, omental caking was present, mild free fluid in peritoneal cavity, lymph nodes are enlarged along iliac vessels left more than right up to 1.1 centimeter with no necrotic changes.
At this point of time, you like to discuss the MRI findings and differential diagnosis, or allow the radiologist to make it a specific comments with reference to endometriosis and pelvic inflammatory disease of granulomatous nature.
Yeah, when you have a omental caking and peritoneal thickening diffusely, I would put two differential diagnoses. One is tubercular peritonitis. The second one is peritoneal carcinomatosis rather than endometriosis. Endometriosis can be multifocal, but it cannot be diffuse omental caking. There are rare case reports, but not common. So
in
that
momental caking, it will be
usually
focal but not generalized.
Generalized, yeah. It's like extending from the omentum up to the pelvic cavity, diffusely involving multiple areas, and some lymph nodes are there. They are not necrotic. So tuberculosis and peritoneal carcinomatosis would be leading possibilities unless until proved otherwise.
In this study, she not conceived.
No, sir.
Am I right?
She conceived.
Then how long she having the other components of pelvic pain after the
Only
first delivery?
No, sir.
Duration of illness post delivery. Because the abdominal finding, can the momental cake can be made by high resolution ultrasound?
Yes, you can see omental caking and peritoneal thickening. You can see in ultrasound. But overall assessment MRI or CT is better.
But in resource component, the omental cake with this picture of some amount of pelvic inflammation and ancestral components of fluid and regional lymphadenopathy and standing all make towards more of a tropical disease than
Infection, yeah.
MRI impression, primary mixed severe pelvic endometriosis with omental or peritoneal involvement and pelvic inflammatory disease. Differential can be abdominal tuberculosis, infective etiology. Patient has been posted for diagnostic laparoscopy for omental biopsy. During laparoscopy, when we were unable to pass ports as there were adhesions, so procedure was abandoned and expedited laparotomy converted to laparotomy. Intraoperative
he
findings.
had difficulty in laparoscopic insertion itself.
Yes, sir.
Why? As a resident, you must answer. Therefore, the entry point itself is adherent. The policeman is very vigorously robust and obese.
Yes.
The policeman who is guarding it not with efficiency but with deficiency.
Intraoperative findings were thickened peritoneum with tubercles and nodules. Thickened nodules, omental cake is present. Loops inseparable due to dense adhesions. Dense adhesions between bowel loops and abdominal wall unable to separate individual bowel loops, which is a hallmark of chronic peritoneal inflammation.
As a resident, the moment he could not pass that laparoscopic instrument, in this case with the finding of omental cake of that magnitude, if you further proceed, the patient will go to hell with perforations and all these things. You must close, immediately hand over to the respectful physician or pulmonologist to start the drugs in which the omental cake slowly disappears at the end of 2 months to 4 months. This is one of the commonest and finest presentation of wretched tuberculosis of the abdomen. Wonderful presentation. Go ahead.
First image shows cocooning of bowel loops. As this was present, so laparoscopic ports has not been were unable to pass. Second image shows peritoneal nodules. And first image shows peritoneal nodules over the abdominal wall. And second image shows peritoneal nodules. Montu test was done, which is negative. CB net of acidic fluid was also done, which is negative. A mental biopsy was sent for histopathological examination, which showed a mental tissue dense, fatty tissue with congested blood vessels, well-formed granulomas with caseous necrosis and Langerhans gene cells, lymphocyte predominant collections with areas of hemorrhage, and lymph nodes granulomatous reaction was noted. Conclusion: omentum, caseating granulomatous inflammation, probably Cox etiology. Final diagnosis was TB abdominal tuberculosis, peritoneal or mental involvement, which is of wet adhesive type peritonitis. Confirmation is by caseating granulomas on biopsy. Patient was started on anti-tubercular therapy. Patient recovered well. Suture removal was done on POD 10. Patient is discharged on POD 12. Patient is on regular follow-up since 2 months.
At this point of time, for the treating doctor as well as the pulmonary physicians, we like to advise the only anti-tuberculosis treatment, anything beyond, because of this magnitude of adhesions as well as momental cake of plastic adhesive type of tuberculosis. Dry, plastic, fibrotic, adhesive, 4 variants. Any comments from the faculty of pulmonology? Yeah. No, sure. That's what you last me. You are also pulmonologist? No, go ahead. Come in. Can be given or should be given or may be given? My question is that. Academic.
Already there is admissions already formed, there is no role of steroids in this. In the acute phase, like inflammatory phase, if you give steroids, it will be prevented.
Therefore, there are all recommendations coming from the West where there is not much literature or amount of exposure of that. But on all momental cakes from the Eastern component and the African experience of South Africa, if you don't give steroids, they land with a recurrent amount of subacute obstructions and the life made hell for them. And therefore, the steroids are given about 15 days of maximum intensity, provided you take care of all the things, rest of the things. Why there is no double-blind study? Because there is a rarity of it. We cannot have a double-blind study in this. But there is a lot of series of studies of 19th century, 19th century late part and 20th century early part. Therefore, I would advise him about 20 milligrams of common cartil, provided you are sure that he is able to tolerate it, and for 2 to 3 weeks. Then the one will take. But when you give steroids after laparoscopy like this, the momental cake will be converted into a secondary bacterial abscess.
So what did you learn from this? What should you have done? We had a case when I am a geologist. Father-in-law was doing that section. He was doing that as a cake. Suppose when you did, you couldn't enter the peritoneum. You could take a biopsy of that. This frozen section. You will know the diagnosis. Right? Because by opening that, it's ready. Just we gave for that patient where we did a biopsy and with anti-tuberculous drugs completely cured. Came out like a rose. That's what we do. So you are going to think, you want to know what it is. It is only the tissue that can give you the diagnosis. Either endometriosis, we know it's not. It won't form like that. We need tuberculosis. It is there. But retreat, biopsy, treat. Did she lose weight? You didn't mention. What is their BMI? What was the loss? How much did she lose? How is appetite? These are all the things which should have directed you to know that there is something.
Negatives.
The interpretation of Manto I am not authorized to comment. It helps you, you take it. If it doesn't help you, it tells you that there is some tuberculosis. Or exposed or not exposed, not beyond that. It is like an untrained ultrasonologist making something cystic. In the anatomical region, it may be anything. But MANTO is very useful when you want to interpret it in the light of immunocompromised like HIV, where in which you can treat it if it is more than 5 millimeters of inhalation, can unequivocal evidence of tuberculosis. Ulcerative form, even any individual is amply reactive and he should be given about a secondary prophylaxis of 3 months of antibiotics.
Is she immunodeficient?
No, ma'am.
Mantu has to come. It has not. She is having proper immunity. It's not. That should come as positive. But here it is negative.
Very nice, your voice is good, everybody is able to hear you, but things I keep repeatedly I keep telling you. You have to know certain things, you have to find your own residents, you present and ask them to correct you. The font is so slow, you are wasting your voice. You have to do that. And there is no need to say coming to, if you come, you should have told about 30 times or 40 times. So there is no need to that. This is, for us it's okay. When you are presenting in other areas, they will think that we haven't taught you even that much of that. Please, don't misunderstand. It's not you alone. I keep repeating for the last 25 years. I keep telling I have presented, every year I present how to make slides, what the font should be. But you are not learning. You are resistant to learning. That you should shut and come and do that, I can do this. I have told several times. That's and somebody should hear you, your colleagues, and they should correct. Okay? Don't misunderstand. Okay? God bless.
Thank you, sir.
Outside it was, the MRI was taken and they thought it was a tuberculosis of abdomen. But by the time we came here, we had done ultrasound and we got our MRI done. So with the pathways are single pathways going to 2 to 3 pathways, like endometriosis can be Crohn's disease or the tuberculosis of abdomen, where the tuberculosis lies in the third option. It's not as the first option. So that's why we have investigated the patient thoroughly. So where MANTO is negative and we have posted the case for surgery, that too, as they give ascetic type, we have tried to as you said, we try to get the mental biopsy or whatever the wet type.
Just to not do frozen section.
Yes, sir.
Frozen section, that is the family should come and take it and it will be able to tell you in 10-15 minutes.
Yes, sir.
It will prove that it's going to is tuberculosis.
Yes, sir. So, but the problem here is MANTO is negative, post-operatively we sent for CPNAT, it is negative.
Yes.
And the histopathology, they are giving us query box print.
That is the beauty of tuberculosis.
Yes, sir.
Tuberculosis always will be confirmed by histologically in less than 50% of cases.
Yes, sir.
And tuberculosis can be confirmed in exudative phase less than 2/3. That means 25 to 50% of tuberculosis still cannot be made out. That's why it is still a lingering white plague all over.
Yes.
Number 2, there are certain radiological findings which are unlikely to be present except in tuberculosis. One is a mental case, and that can be only one different diagnosis is myxoma peritonitis, carcinomatous peritonitis. No other things. Therefore, the moment mental case is seen in India, even without biopsy, your resident should start anti-tuberculosis treatment and see them after 4 to 6 weeks.
Yes, sir. But the thing,
here we have to do exploratory laparoscopy to confirm it, but you cannot confirm it. I also tell you that.
But just by doing the laboratory, we can know that
because we are not in a position to take the regional lymph node. You cannot go to the regional lymph node. And momentum contains it is already gone for fibrotic phase with multiple nodes. We cannot take the entire momentum because there are so many loops and they'll put it into going in, like the earthworms in an English mass of things.
Yes.
Right, wonderful case. I thought you are presenting serious.
Empyema with a twist, unusual phases of tuberculosis from Department of Pulmonary Medicine, presented by Dr. Vaishnavi, Junior Resident Pulmonary Medicine. Session will be moderated by Dr. Bhanurekha, Professor and HOD Pulmonary Medicine.
Good afternoon, I am Vaishnavi Pulmonology resident. A 65-year-old woman, agricultural laborer by occupation, presented with chief complaints of dry cough since 10 days, fever since 4 days, generalized weakness since 4 days. History of present illness, patient was apparently asymptomatic 10 days ago and presented with complaint of cough since 10 days, insidious onset, gradually progressive, no postural or diurnal variation, no aggravating or relieving factors, not associated with sputum. Complaint of fever since 4 days, low grade, intermittent, not associated with chills, rigors or myalgias, not associated with burning, maturation, vomiting, loose stools, and complaint of generalized weakness since 4 days, complaint of loss of appetite since 10 days. No complaint of breathlessness, wheeze, chest pain, hemoptysis. Past history, no history of similar complaints in the past. She is a known case of diabetes since 2 years, not a known case of hypertension, pulmonary tuberculosis, bronchial asthma, CKD, CVA, thyroid, and COVID-19. No history of allergic manifestations to dust and cold exposure. No history of inhaler usage. 2 doses vaccinated for COVID. Personal history, takes mixed diet. Sleep is normal. Appetite is decreased since 10 days. Bowel and bladder movements are regular. There is a biomass fuel exposure. Non-smoker and non-alcoholic. Family history is nil significant. Menstrual history attained menopause 15 years back. General physical examination. Patient is conscious, coherent and cooperative. GCS is 14/15. Oriented to time, place and person. Moderately built and moderately nourished. BMI is 21 kg per meter square. Pallor is present. No icterus, cyanosis, clubbing, generalized lymphadenopathy and pedal edema. Vitals at the time of presentation. Temperature 98.6 Fahrenheit. Pulse rate is 98 beats per minute. BP 110/80 mm of Hg. Respiratory rate is 20 cycles per minute. Saturation is 96 at the rate of room air. Systemic examination. Upper respiratory tract. Nose is normal and oral cavity is also normal. Lower respiratory system. On inspection, shape of the chest is elliptical. Symmetry bilaterally symmetrical. Trachea appears to be in the midline. Chest wall movements appears to be equal on both sides. Apical impulse is not visible. No visible scars, sinuses or engorged veins. On palpation, all inspectory findings are confirmed. No local rise of temperature or tenderness. Trachea is in midline. Chest wall movements are equal on both sides. Apical impulse felt in left fifth intercostal space, half-inch medial to mid-clavicular line. Ocal frontis is equivocal. No intercostal fullness. On percussion, direct percussion, clavicle is bilaterally resonant. Sternum upper 2/3 is resonant, lower 1/3 is dull. On indirect percussion, bilateral lung fields resonant in all areas. Chronic systemus is bilaterally resonant. Liver turnus elicited in right fifth intercostal space. Thyroid percussion elicited in right sixth intercostal space. On auscultation, bilateral normal vesicular breath sounds. Coarse inspiratory traps in left lower infrascapular area, infraaxillary area and right infrascapular area. CVS S1 and S2 are heard. CNS, no focal neurological deficit. Per abdominal examination, soft,
You commented on the vocal perimeter is equivocal, but you are not confirmed the vocal resonance, which is a much clinically reliable thing than vocal perimeters. Why you have not evaluated the vocal resonance?
Vocal resonance is also equivocal.
What do you mean by equivocal? Because I am hearing it the time first.
There is no increase or decrease.
Then what it is? There should be something. Suppose breath sounds are absent or heard and decrease in intensity.
Equal on both sides.
I'm not interested in equal. Both sides should be equal. You mean to say equivocal?
Provisional diagnosis, bilateral lower lobe consolidation, left more than right. X-ray at the time of presentation.
It's a frontal chest schedule of AP view, and we can see multiple radiolucent cystic lesions with consolidated changes in the left lung field. And also we can see a homogeneous opacity in the left aspect of left lung field. It might be pleural effusion. Right lung field is clear to the visualized extent, and right dome of the diaphragm and costophrenic angle are clear.
We are seeing that a convexity towards medial aspect like this too. You cannot call The convexity towards median aspect is a pleural component of normal effusion. The pleural effusions will have concavity outwards, but convexity outwards, concavity inside. When you are seeing independent amount of convexities inside like this, that is only two differential diagnosis, radial or pleural. One is an ancestral effusion, two is an embryon. Comments from your side, sir? If you say, another important point as a radiologist is, the level of density of lesion width is more high and less lower. That is gravity independent. Third point. That's all. Therefore, after seeing the chest X-ray must say an ancestral effusion or otherwise longulated something, or extrapleural embryon from the vertebral body of the rib as a valid.
Valid ECG showed sinus tachycardia at the time of presentation. Lab investigation, CBP showed anemia. In peripheral smear, there is microcytic hypochromic anemia. WBC count showed or increased 30,000 with neutrophils predominant. Platelets are 3,77,000. Vitamin B12 is 996. Retic count is 0.88%. RFTs, serum creatinine is 1.6. Serum urea is 91. LFTs are within normal limits. Serum electrolytes, potassium is 3.4. Virals non-reactive. HbA1c is 7.7. FPS 150. ppbs 227. RPS is 284. CV is within normal limit. Sputum analysis, CB9, AFP and gram stain culture sensitivity are negative. Patient was started on injection cefepime plus tazobactam 1.125 grams IV 12th hourly, tablet clarithromycin 500 mg 12th hourly, tablet linezolid 600 mg 12th hourly, Pantop 40 mg IV 24th hourly and human actropate according to GRBS. Ultrasound abdomen and pelvis, bilateral renal calculi, bilateral increased renal parenchymal echo pattern. On day 3 X-ray,
we can see air fluid levels in the left lung field, which are indicative of hydropneumothorax. And the rest of the findings remain same, that is the cavitary lesions mixed with the consolidated like changes are still persisting.
yes. Before needle is the X-ray.
I must explain. It makes a lot of problem. Go ahead and talk about the radiology. The permission of the radiology.
These are axial, coronal and sagittal CT images of the chest showing the presence of cavitary lesions in the left lung field with the collapse of the lung. We can also see the presence of a mild amount of pleural effusion with air fluid levels suggestive of hydropneumothorax.
We heard about the pneumonic consolidation broken down. Very unusual. And pneumonia, unless it goes into a necrotizing component in the predisposed individual, it will never break down and cause like this. It can cause empyema, symptomonic empyema, metapneumonic empyema. But the fluid air levels, that denotes, that's why I asked you the question, is it prior to the aspiration or post? That is important. Because we use the word biofuel and all sorts of things, and there is a differential density of convexity because when the fluid collects in the lung and the pleural cavity, if it collects with the density of it, you are taking a cross section of it. At this point, it may be thin in the lower part, but the collection goes up consistent more, then you have differential curvature because it is a chest X-ray, is not a 3-dimensional. Then that type of empyema occurred, that collection, whatever it is, unsystematic, and immediately gone to this, that child should be parenchymal disease for it to convert into a hydropneumothorax. That means it is not a primary pleural, it is associated with a parenchymal disease, invariably tuberculosis, not biophilia, because you are not made out an emphysema, blood. Therefore, that given way, and you have got hydropneumothorax of these things. Suppose if you put a needle, then it becomes something else. Post. Thank you.
CT chest report showed there is an evidence of fibrocavitary lesion seen diffusely involving left lung field more so in upper lobe, associated with significant collapse of entire lung field, likely sequel to old infection. Free bird opacity seen involving posterior segment of right upper lobe, possibly infective etiology, tubercular bacterial. There is evidence of patchy consolidation seen involving left lower lobe. Mild amount of fluid noted in the left pleural space with air fluid levels suggestive of hydropneumothorax. 24 French ICD was...
You like to rule out bronchopleural fistula? What you made a diagnosis of hydropneumothorax with a cavitary component and not heterogenic. You should be invariably bronchopleural fistula, nothing else. Why do you query? Make it. There is nothing like query in clinical medicine to be clarified, non-querying.
24 French ICD was inserted in left 6 intercostal space. Gush of air and pus of 550 ml collected in the ICD bag. Tube is patent. Column moment is present. Bronchopleural fistula is seen. Pus is sent for microbiological, biochemistry, pathological analysis. Antibiotics were escalated to injection meropenem 1 gram 12th hourly. Post ICD X-ray.
Post ICD, we can see the resolution of fluid collection, but the pneumothorax is still persisting.
Pleural fluid analysis.
So those are the cavitary lesions that we saw on the. Like the fibrocavitary lesions, hence the thick wall. Pleural fluid analysis, cell count is 9,000 cells, neutrophils 95%, lymphocytes 5%, glucose is 63.4 mg per dl, protein is 4.63 grams per dl, LDH is 5,535 international units, ADA is 32 units per. Malignant cells, no malignant cells seen, CB net is positive and rifampicin is sensitive, AFP smear positive for acid phos bacilli 2+, KOH is negative for fungal elements, cultural sensitivity, no bacterial growth. Patient was initially...
Smear is from the fluid or the expectoration?
No sir, fluids. Patient was initiated on ATT, 4 tablets, tablet Benadryl, 40 mg, half OD, ensured protein powder, 2 scoops in 1 glass of water or milk. Final diagnosis.
You must write the content, madam. They are not coming from Denmark. Benadryl, Pyridox.
Final diagnosis, acute left pneumothorax, tuberculous empyema with uncontrolled type 2 diabetic mellitus. Discussion, tubercular empyemothoracis represents a severe and relatively uncommon manifestation of pleural tuberculosis characterized by the presence of pus in the pleural cavity with demonstrable Mycobacterium tuberculosis. Unlike tuberculous pleural effusion, which is typically paucibacillary and immunologically mediated, tubercular empyema is a multibacillary disease associated with chronic infection, extensive pleural involvement and significant morbidity. Pulmonary tuberculosis accounts for approximately 5 to 10% of all tubercular cases, while empyema due to tuberculosis constitutes about only 1 to 5% of pleural TB cases. This case highlights an acute presentation of tubercular empyema, which is relatively uncommon as most cases of chronic are diagnosis. Chronic empyema constitutes the majority, around 60 to 80%. Acute empyema accounts for a smaller proportion. There can be co-infection with conventional aerobic and anaerobic bacteria. The presence of hydropneumothorax in imaging test should lead to the suspicion of bronchopleural fistula. Patients with tubercular empyema are usually allosymptomatic, manifesting non-specific symptoms. Acute TB empyema provides a window of opportunity as early intervention can prevent fibrothorax, restrictive lung disease and major surgeries. Prognosis is better compared to chronic stage. Prompt and early initiation of anti-tubercular treatment in such patients of empyema can improve the prognosis of the patient and reduce the risk of complications associated with long-standing pleural infections such as pleural thickening.
And interaction. The faculty moderator.
So the purpose of presentation in this case is initially the patient presented with a very non-specific symptoms. There is no history of cough and expectoration, only dry cough and fever of 4 days in duration. So on the clinical examination also there are no signs of toxicity. Patient doesn't have chest pain also in the symptom. On examination also there is no tenderness or no localizing signs. So we thought initially it is a simple viral infection from the presentation. And after seeing the X-ray, we see there is a left upper lobe cavity, which is a sign of old heel tuberculosis. She doesn't give the history, but there is a thin-walled cavity in the left upper lobe. And in mid-jaw, there is a multiple cavities denoting of necrotizing pneumonia with a pleural effusion. So under the underlying condition of uncontrolled diabetes, we thought it can be a pyrogenic infection. But later it is complicated as a pyrogenic.
One point you made out. Their general condition is asymptomatic for a long time.
Only 10 days duration, sir.
Rectal fever. And necrotizing pneumonia with some amount of synapses cannot have without a conscience. That is one of the important clinical
So that's why,
which should make you to alert that it is tuberculosis. Number one.
Yes, sir.
And why am I interested in this?
Radiologically, there are necrotizing, sir, multiple cavities.
That's what I'm talking. Those cavities are not necrotizing pneumonitis of any pneumonia breaking it into such short time without the deterioration of the general condition, because that can happen only in two conditions. That type of massive necrotizing abscess of like that. One is a septic pulmonary MLS of the purpureal brain, in which they are all very toxic. If that lung is due to necrotizing pneumonia going into cavitation of that magnitude, should have a hectic amount of clinical. But clinically, she is apparently normal, which should make you suspect that is a tuberculosis cavity. Number one. Two, tuberculosis empyemas were now a rarity because you are not seeing it. But in tuberculosis hospitals and in our chest disease hospital, there is no time in which one hanging fellow with this component of pink tuberculosis.
Most of the times we will be seeing as a chronic complication, sir, not in acute conditions.
This is not acutely presenting. It is presenting because of the recent infection of fever, but the disease is present for a long time. That's what I'm saying.
No, that's
an acute presentation of fever, but no symptoms suggest of lung.
The sequence of events, if you see, initially there is only empyema, sir. Later it ruptured and causing a hydronemothorax with a bronchopleural fistula. It is not a chronic one. It is going in acute phase.
That's why. When you go back to this slide, the upper part there is an encystment. That means it's first slowly leaked. That itself is a sign.
So upper part there is a
radiologically it doesn't look like subacute, it's chronic. It's not acute. That's not looking like a picture of necrotizing pneumonia. It's like chronic ongoing tuberculosis fibrocavitrary disease which is still active. That's why it's reactivated from the pre-existing disease.
Yes, sir. In the left upper zone, that is a thin-walled cavity. I agree that is a old heel fibrosis, tuberculosis. Mid-zone, you see there is a multiple thick-walled cavities.
Yeah.
There can be a reactivation of tuberculosis there.
Yeah, reactivation. Old and new mix.
Yes.
Raise the hand. Last spectacle. Anything to say? Anything more? Poster. How long you followed it and where it? Anything?
We discharged the patient with ICD, sir, as there is a bronchopleural fistula. Some follow-ups in the patient history.
Here, why I asked is, if the fluid is positive for tuberculosis bacillus. The moment fluid is positive for tuberculosis bacillus, that magnitude. How many positive tuberculosis bacilli seen in your pleural effusion so far?
sensitivity is less than 50%.
I'm asking how many years here, I don't want that temporary words of statistics. State, have you 100 pleural fields, have you seen 2 positive tuberculosis demonstrated in the pleural plate? The moment you demonstrate a pleural plate positivity, it is unequivocal evidence that is an active lung pulmonary parenchymal. That's all. Anything more? Any? Sir, any? Only